And today, it's my pleasure to present the AAAP Founders Award. The Founders Award this morning will be presented to Dr. Laurence Westreich. Dr. Westreich is a psychiatrist who specializes in the treatment of patients diagnosed with co-occurring addiction and other mental health disorders. He received his medical degree from the University of Minnesota School of Medicine, and following an internship in internal medicine at the Hennepin County Medical Center in Minneapolis, Minnesota, he completed a residency in general psychiatry at New York's Beth Israel Medical Center, and then a fellowship in addiction psychiatry at the New York University School of Medicine Bellevue Hospital. Dr. Westreich is board certified by the American Board of Psychiatry and Neurology in general psychiatry, addiction psychiatry, and forensic psychiatry, and he is also certified as a medical review officer by the Medical Review Officer Certification Council. He is an associate professor of clinical psychiatry in the Division of Alcoholism and Drug Abuse at the Department of Psychiatry at New York University School of Medicine, and he also serves as a consultant on behavioral health and addiction to the Commissioner of Major League Baseball. He's the author of 2 books, Helping the Addict You Love and A Parent's Guide to Teen Addiction. He is also the past president of the American Academy of Addiction Psychiatry. In his professional practice, Dr. Westreich treats individuals with substance use and other co-occurring psychiatric disorders, and he also serves as a consultant in forensic matters, especially focused on drug testing, child custody disputes, and disability. At AAAP, we know Dr. Westreich as an outstanding colleague, smart, thoughtful, always willing to assist AAAP in its efforts for advocacy, training, and membership. He recently spearheaded AAAP's new interest group in addiction and the law. And for all this and for all his other many contributions, I'm really thrilled to have the opportunity to present to him AAAP's Founders Award. Please welcome Dr. Westreich. I'm going to give you a hug, and then I'll give you a plaque. So I want to just read the plaque that I'm going to give Dr. Westreich. It says, in recognition of your steadfast support of education, treatment, and policies supporting those with substance use disorders and co-occurring mental disorders, your passion, relentless championing, and fearless advocacy for equity in the prevention, treatment, and commitment of care has had far-reaching benefits for patients, their families, and communities across the nation. So, my pleasure.
Thank you. I'll take a picture.
Thank you. And with that, Dr. Westreich.
Thank you. Good morning. When my friend Shelley Greenfield called me to say that I would be presented with the 2019 Founders Award, I was gratified and honored and grateful. I was also a little bit mystified. Usually this award goes to gray-haired individuals with long careers in the field. When I mentioned my confusion to Lisa, my wife, she suggested a quick glance in the mirror. She says that a lot. Speaking of Lisa, when people give talks like this, they usually thank their academic collaborators at the end, which I will certainly do. But my most important collaborators are Lisa, Noah, Tali, and Ari. I'm going to be talking mostly about addiction psychiatry today and what makes practicing it a joy. But I can say for certain that having a family I love very much and actually having the time and energy to spend with them has allowed me to find joy in my work. I hit the lottery with each of them, and I will tell you that their support and love and occasional confrontation has kept me focused and present in my work. And their patient forbearance has allowed me to pursue passions like Arabic and working at a summer camp and going to random history lectures. So you know, my title today is Career Opportunities in Addiction Psychiatry. It's the title of a course I teach for the Addiction Psychiatry Fellows at NYU, but I've today tacked on the qualifier, or how to find joy while practicing addiction psychiatry, because that's actually what I'm going to talk to you about today and what I try to get at with the fellows. I will talk about some of the bumps and bruises I have had along the way, and I'm going to talk about the men and women of the American Academy of Addiction Psychiatry and where I think our field should go from here. I'm delighted to be speaking today before we hear from David Sheff, who with his work has eloquently shown the pain of addiction in his own family and has given a recognizable face and name to addiction for many of his readers. If you haven't read his book or seen the movie, I urge you to do so. I'm happy to be talking to colleagues and friends who I've known for many years, this time about a much more personal subject than I usually talk about. We usually talk about addiction policy or AAAP business or the latest research, but today I'm going to talk about how I think you can find joy in your career. I'm even happier to be talking to the medical students and the trainees and junior faculty in the room. I hope you will see a way clear to having a long, fruitful, and joyful career in the service of helping people with addictive disorders. On my fourth year medical student rotation in psychiatry at the VA hospital in Minnesota, Mark Willenbring and Joe Westermeyer were faculty members there. They had a student-run patient interview scheduled for the second day. I was very interested in psychiatry, so I fully intended to volunteer to be the student interviewer for the little class. Like the eager young medical student I was, I tried to game the system by guessing what exact diagnosis I was going to see the next morning in the session. I memorized the DSM-3 criteria for PTSD, not a hard guess given that it was a VA hospital. And when Dr. McGraw led the patient in the next day, I asked my first open-ended question, as I had been told to do. Bingo, bad experience in Vietnam. And so I went into what I had learned in my medicine and surgery rotations, which is called symptom pursuit mode. I took the hints the patient gave me and drilled into the categories and subcategories, trying to pin every symptom to the wall and demonstrate for my teacher what a smart and well-read guy I was. As you can imagine, I had the patient distraught and in tears in about 3 or 4 minutes with my hapless and insensitive probing of his psychic wounds. At that point, I had no idea what to do. Luckily, Dr. McGraw stepped in and said, "Larry, why don't I take it from here?" He finished the interview up as best he could, helped the patient recompensate, and led him back to the ward a few minutes later. When he came back, we started a discussion about the psychiatric interview. The first thing, very important, Dr. McGraw agreed with me, was to know about the symptoms and the real diagnosis. But there was this other thing, he said, called the therapeutic alliance, in which the interviewer tries to establish a sense of connection and trust and empathy with the patient in the hopes of both understanding the patient and coming to a mutually agreed upon treatment plan. This was clearly a newsflash to me, but it is a construct which I've held dear throughout my career as a psychiatrist. I was born and raised in Minnesota, the land of 10,000 lakes. My dad is a neurologist. My mom was a physical therapist who raised 4 boys. Over that time, she developed a very strong personality, shall we say. One of my brothers is an obstetrician. One of my brothers is a nurse. One of my brothers is a lawyer. My dad informed me when I took on forensic psychiatry that if my brother or I ever participated in a malpractice suit against a doctor, we would be excommunicated from the family. I didn't know Jews could do that, I told him, but my pleas fell on deaf ears. As a product of a fascinating high school internship at the University of Minnesota liver transplant lab my senior year, by the time I got to college at Northwestern, unlike many of my less focused classmates, I had a firm understanding of my career path. I was going to be a surgeon. I plodded through the pre-med courses those first few years, but finding a lot of stress and not much joy in the classes and the competition, I switched to English literature when I was told that med schools didn't much care what your major was as long as your science grades and MCATs were okay. I certainly enjoyed reading King Lear and As I Lay Dying and Lolita and writing papers about my impressions of those books, but I was still focused on surgery and fully intended to extract gallbladders during the day and read interesting books about people in the evenings. After college, I spent a wonderful year in Jerusalem, at that point reading more books and struggling with Hebrew and Arabic, but the next fall I found myself a first-year medical student at the University of Minnesota School of Medicine. I was living in my parents' 3rd floor and memorizing the Krebs cycle and the brachial plexus. Back then, the first 2 years were all classes and labs, and I was deeply excited to get to my first clinical rotation, where I was determined to come out of the gate quickly by doing a coveted orthopedic surgery elective rotation, which I found, after a few days, boring. Same with my general surge rotation. Okay, bad news. Time to reconfigure a few career plans. I really liked the intellectual challenge of both internal medicine and psychiatry, where my initial splashdown with Dr. McGraw into the idea of talking with patients at the VA had actually morphed into a fascination with schizophrenia, the thought disorders that attend that diagnosis, and the cultural manifestations of those thought disorders. I had a spectacular fourth-year medical student rotation in the highlands of Guatemala at the Bear Horse Clinic, where I was able to see the same psychoses I had seen in Minneapolis, but filtered through the culture of an indigenous population with very little connection to the outside world. I also saw infectious disease and malnutrition syndromes unheard of back in Minneapolis, for which nothing but rudimentary care was available. It got me fired up about general medicine, and I chose to apply for an internal medicine residency, which I thought I could always switch to psychiatry if I didn't like it. I liked it, but I noticed that my fellow residents, entranced as we all were by our experiences treating and sometimes even helping severely ill patients, seemed to like it even more than me. When we had a chance to hang out in the library, I would notice them boning up on a nephrology journal, and I inevitably selected a certain journal with a green cover to peruse. That should be a clue, I thought to myself. So I called Dr. Golden, the residency director for my med student rotation at Beth Israel, New York, and asked him if there were any spots for a second-year resident. Luckily, there were. And even more luckily for me, my bride-to-be, Lisa, agreed to uproot herself from Minnesota for 3 years so I could do the residency which I coveted so much. It's been 30 years now. Sorry, dear. But it's not entirely my fault. She got into grad school, I got a fellowship, we liked Brooklyn, like that. My residency at New York's Beth Israel Hospital was another revelation to me. They had a quite substantive research and teaching program about psychotherapy, and residents could join in. Arnold Winston, Harold Bean, Rick Rosenthal, and Henry Pinsker demonstrated for me the peculiar power of that intimate engagement of a psychotherapeutic relationship, even or probably especially with the addicted person. It turns out they had heard of Therapeutic Alliance also. My residency years from 1989 through 1992 at Beth Israel, whose catchment area is Manhattan on the east side below 23rd Street, taught me much about AIDS and crack cocaine. Several dedicated and dynamic clinicians and researchers, Rick Rosenthal leading them, demonstrated what perseverance and courage and true intellectual curiosity can do, even in the face of scourges like AIDS and cocaine. I pretty quickly dropped my goal of becoming a schizophrenia researcher and hopped on the bandwagon of addiction and dual diagnosis. To a large degree because I saw my mentors and colleagues doing an enormous amount of good for their patients and being gratified by their success, entirely unfazed by relapse or overdose or being lied to. I admired and tried to emulate their steadiness in the face of challenge. I vividly recall one time bursting into Rick's office and telling him we needed to call the police because I had a patient in her home who had been using cocaine and sounding hypomanic to me. He said to me something along the lines of, "Larry, in this business, if you're this riled up about a relapse, you're going to be riled up a lot." Good advice. The Beth Israel residency program taught me and the other residents about the value of engagement with our patients through psychotherapy, allowed us to participate in research projects in psychotherapy, and even gently suggested that a course of psychotherapy for me might be both professionally and personally useful. A suggestion for which Lisa has been told me she's eternally grateful, and which she says might be the reason she has been able to stick it out with me for 30 years. In any case, my training at Beth Israel provoked a career-long interest in psychotherapy. My resident research paper was titled A Preliminary Study of Therapeutic Alliance and Dually Diagnosed Inpatients. I was starting to catch on to that whole Therapeutic Alliance deal, I guess. After residency, I followed my new friend Charlie Silberstein and applied to the addiction psychiatry residency at NYU Bellevue, which was then a 2-year program. I had the privilege of spending several years learning and doing research and practicing addiction psychiatry under the tutelage of Mark Galanter, Ed Paul, and many other talented faculty members and more senior trainees. I learned about the network therapy approach for building a therapeutic alliance not only with my patient, but with his or her family or friends, all in the service of bolstering those behaviors and attitudes which can support sobriety. I imagine I use those techniques every single day in my practice. Also during my fellowship at Bellevue, I found myself on many Tuesdays testifying in the 19th floor in front of a New York State Supreme Judge about why a patient should be held against his or her will or medicated over objection. These were serious trials, as they should be, and my testimony was attacked as biased, irrelevant, or just plain stupid by the mental health legal services attorneys in their roles as advocates for their patients. I was struck by the fact that this court, in addition to the pretentious matters decided there, was a different culture right there in the middle of Bellevue Hospital. The lawyers clearly had a different language they were speaking to each other, but they also had a different set of clarifying underlying values. They were there to assure that justice prevailed, though they had clearly opposing views about what that justice should be, while the doctors and nurses and social workers up on the wards were trying to help the patients return to a state of mental health or sobriety. Don't get me wrong. The lawyers and judges were also trying to help the patient, but their goals were different. We had health as an outcome, and the lawyers held justice, or at least victory, as an outcome. Frankly, the cultural disjunction there fascinated me, especially as I got to know some of the lawyers, who would regularly spend 15 or 20 minutes trying to embarrass me on the witness stand, then nonchalantly invite me to join them in the cafeteria for lunch. I learned enough over sandwiches with those lawyers in the Bellevue cafeteria to convince me that the board certification in forensic psychiatry would be worth it, and with some encouragement from mentors like Michael Gendell and Rich Francis, I pursued that education and weathered the hard knocks of being a novice expert witness in courtrooms far less collegial than the one at Bellevue Hospital. I learned about the dual agency problem, in which a forensic psychiatrist has obligations both to the human being sitting in front of him or her, as well as to some other entity, like the court, or an employer, or a hiring attorney. This is an uncomfortable dynamic which doesn't exist much in clinical psychiatry, but it's one which must be managed and is one reason a lot of psychiatrists don't like to do forensic psychiatry. This example is called the therapeutic use exemption, in which an elite athlete has to be allowed to take a banned medication, often a stimulant for ADD, sometimes testosterone, sometimes albuterol. This is in order to treat his or her diagnosed medical or psychiatric problem. The clinician has an obligation to the athlete looking for a rules exemption to take care of that person. But the clinician also has an obligation to the sport itself to maintain a level playing field for all the athletes. This is a difficult and awkward position to be sure, but one that needs to be managed in most, if not all, forensic situations. After my fellowship, I was privileged to serve as a unit chief on Bellevue's detoxification unit for several years and the dual diagnosis unit after that. I learned a lot about opioids and about dual diagnosis and about teaching in a huge medical system. I had a series of mentors who taught me about hospital politics, about taking care of very ill patients, about handling relapse, and about raising a family as a young professional. After moving from Manhattan to Brooklyn and then New Jersey, it became clear to me that spending the day at the hospital and then working in my private practice in the evening was not working for me and my young family. I decided to make the move from academia to private practice regretfully, because I loved the overflowing psychiatric opportunities to learn at Bellevue. Luckily for me, NYU was and is flexible enough to allow me to remain engaged with the hospital and trainees, teaching, attending lectures, etc. Thus the class. Building a career in addiction psychiatry, my contribution to NYU's psychiatry fellowship. I participated also, after taking the forensic psychiatry boards, in a variety of forensic cases, mostly related to addiction, child custody, criminal matters, and some elite athletes, including the NFL. Because I was comfortable both with addiction and with testifying or being deposed, and with a push again from Rick, who also worked in the NFL, I was hired by Major League Baseball in 2003 to help spruce up their drug program. This is a cartoon from the time. The athlete says, "I'm getting worried about all these steroid hormones, coach." And the coach says, "Don't be ridiculous, Jennifer." This is not where we are now. In one of those sickening roller coaster drops one feels, I quickly became aware when I came to baseball that my knowledge base about anabolic steroids and other performance-enhancing drugs was approximately zero. Luckily for me, I again found mentors and colleagues who helped me understand not only the science of what I was dealing with, but the culture of elite sport. In addition to learning lots of new and interesting facts, I met lots of new and interesting people. Athletes and athletic trainers and umpires and lawyers. Lots of lawyers. And my colleague John Mariani, with whom I evaluate patients with addiction problems and continue to learn from all the time. I'm deeply proud that I have been part of a team advocating for seeing addiction as a treatable medical condition, for assuring that Latino athletes have the same access to services as others, and expanding the accessibility of mental health services within our sport. To the extent that I've been able to push these sorts of initiatives forward is because I've not only presented the science and the data, but because I've remembered my lessons about therapeutic alliance, not only with patients and forensic subjects, but those we have to convince about the necessity for compassionate and effective treatment of mental illness. In all of these spheres, in my training at Bellevue Hospital, in private practice, and in elite sport, it has been an absolute joy to work with people suffering from addiction. That's because it is a privilege to be with another human being on that road to sobriety or mental health. I say that very carefully, because one thing I learned very early is that unreasonable expectations don't help me, and they certainly don't help my patient. I learned from Ed Kansian and Shelley Miller and Ed Kaufman and Kathleen Brady and Herb Kleber that expecting immediate cessation of addictive substance use or a pill to magically produce mental health would be as silly as it would be counterproductive. And yet, it is a regular experience in my workday to see people feeling and looking and acting better than they did just the previous week. These good results happen all the more quickly and sometimes shockingly with addiction. I've come to appreciate the small victories my patients have, having a boyfriend or a girlfriend, passing a class that they never could have gotten up for last semester, 3 weeks of no use, all victories. This fall, a patient shared with me an incident which had happened over his lunch hour the day before our appointment. And this young man has struggled with opioids and a serious disabling anxiety disorder for several years, before slowly edging into sobriety, then an apartment by himself, then a substitute teaching gig. But on the way back to school after lunch, someone had run a red light and T-boned his car. That accident happened at a low rate of speed, no one was hurt, but his car door was smashed, the stop sign runner's airbags had deployed, and the police were called. Standing next to his car, my patient closely observed the police officer as he looked at both cars, glanced inside the windows, asked if everyone was okay, and then took out his pad and started writing a traffic accident report. Last year, my patient told me, he wouldn't have been able to make the appointment with me because he would have been in jail. That police officer would have looked at his pinpoint pupils, the paraphernalia, the baggies in his passenger seat, and immediately assumed it was my patient's fault because he had been driving while impaired. However, this day, my patient told the police officer he was on his lunch break, had to get back to work, and the police officer gave him the report without comment and sent him on his way. I will tell you that my patient and I both had tears in our eyes when we talked about this incident of normalcy in his life, having sat together during those times when he most certainly would have been in jail or worse. So what has changed in the time I've been practicing addiction psychiatry? For one thing, me. I'll start with what I've learned myself, and what I hope is the theme of this talk, that lifelong learning not only benefits your patients, but contributes to the sense of accomplishment and genuine gratification, which is our real pay for doing this job. But let me talk about two sea changes which have happened since I've been in practice, our approaches to performance-enhancing drugs and cannabis. First, the changes in perception about performance-enhancing drugs. In addition to learning about Therapeutic Alliance, I've learned a few other things along the way. When I started working for Major League Baseball in 2003, I was thrown into the cauldron of performance-enhancing drugs, the 2005 congressional hearings, and the 2006 Mitchell report about steroids in our sport. This was for me a sink-or-swim immersion into a culture profoundly unfamiliar to me, the culture of elite sport. Luckily for me, I again found mentors and coworkers who took the time to educate me about PEDs, the choice involved, the peculiar forces driving elite athletes to take these drugs, and the dynamics which cause an already stellar athlete to endanger his career and reputation by ingesting a substance which he knew to be banned and dangerous. And I learned that although PEDs can be profoundly different from the stimulants, depressants, and hallucinogens I had learned about during my training, there are certainly some similarities, not least of which is the fact that some PEDs, in some dosages, cause the compulsive use and physiological withdrawal you and I can identify as dependence. I was able to learn several new ways of thinking about drug use in the context of performance enhancement, not least of which was that whatever elite athletes do, others will follow, whether they are trying to succeed in sport or not. But that sort of use, the kind that causes more classic physical dependence, usually occurs outside the world of elite sport by less than sophisticated users. For instance, as you can see from this chart from Monitoring the Future, there was a spike in past month anabolic steroid use by high school seniors in the early 2000s. And their use was less directed and strategic than elite athletes. High school kids, males and females, often get their medical advice from the musclehead working out next to them at the gym. In fact, most high school students who use anabolic steroids use them not for athletic success, but to build up their muscles and be buff in the high school cafeteria. If they read on the internet that elite athletes use a certain dose of the drug, they will double it, or triple it, or quadruple it. And therein lies the problem. At those dosages, the young steroid users do experience craving and a crashing withdrawal after the profound depression and sometimes suicidal ideation. It is an unfortunately common scenario that a high school student will be found to be using steroids, his parents will demand that he stop, and he does, with a resultant dysphoria and sometimes suicidal behavior. From a public health perspective, the use of PEDs by non-elite athletes is an extremely troubling trend, and of course much more prevalent than use by elite athletes. I hope that our work cutting down on PEDs in sport has decreased their use among high school kids also. If you want more information on this trend, look at the Taylor Hooton Foundation website, which describes a youth pitcher's use of steroids, his eventual death, and the efforts his parents have made to educate others about steroids. So PED use is a little bit like addiction to other substances, but has substantial differences. And the connection to other mental illnesses like depression or at least substance-related dysphoria is something that I came to understand, and I'm happy to say that I was able to do some education about that myself. At Major League Baseball, along with all the other major sports, we have a newly invigorated emphasis on mental health and on educating our players and employees about mental health first aid, about the Columbia Lighthouse Protocol for preventing suicide, and removing stigma from the idea of mental illness and the treatment for it. I'm proud that mine has been one of the many voices advocating for this position over the years. Frankly, it has been only by being an active learner myself about the culture of sport and the specifics of substance use in sport that has given me the confidence to pull on the mantle of authority and push forward nuanced and effective strategies for actually treating addictive disorders and bringing mental health to the fore by building therapeutic alliances with those individuals who I often find myself saying aren't exactly enjoying their use of substances or their psychological distress or their troubled marriages or relationships. And in a professional career, making a leap into an unknown culture, while initially exasperating and exhausting, can turn into one of those energizing experiences which bring joy to a professional career. It has been my pleasure to be part of a team that has turned the tide against anabolic steroids. Cannabis. Another thing that has changed since I started practicing has been cannabis. In my forensic background, I'll today gleefully avoid most of the data and focus on the ongoing decriminalization and legalization and medicalization of cannabis. When it comes to legalizing cannabis, I feel like I'm a citizen of two countries. In the country where most people live, the cannabis is okay country, people smoke pot sometimes. Certain people who are my good friends and who will remain unnamed smoke a joint occasionally, like at a party, maybe every few years, if someone offers them one if they're in the mood. Seems to work out all right, they feel a little goofy, no apparent consequences then, or the next day, or the next week, or the next month, well, ever. The idea of banning or criminalizing this behavior seems odd at best. But in this other country where you and I live, the country of addiction psychiatry, the citizens' lives are profoundly damaged by the cannabis they use. I don't need an academic paper to identify the fact that the adult high school junior I meet in my office, who tells me she only smokes pot on weekends, but from whom the smell of cannabis wafts the 8 feet from the couch she is sitting on to me in my comfy chair, drifting out of her cargo pants and sandals and dreadlocks to the point I need to pop the window, smokes a lot of weed. And she hasn't gone to school in 2 months. She has quit the field hockey team, and all but a few friends have stopped coming over because she spends all her time in her room smoking by her open window so her parents won't know. I sit in my office with this young person and often her parents, trying to sort out their options for getting back on track, but they don't really connect. Because not only are they in two different countries, but they are really mad at each other because they are trying to communicate and they aren't speaking the same language. At conferences like ours, the data are clear. Of course, 17% of those people who try cannabis will, within 6 months, meet the DSM criteria for a cannabis use disorder. Lots of time getting the substance, effects on school and work and relationships, withdrawal, all that stuff. And the subtle effects on the adolescent brain are measurable and consequential, especially when the adolescent in question is using a lot of cannabis and for a long time. When you're in the addiction psychiatry country, you can't miss the signs of addiction in the patient in front of you. The focus on getting the substance, the putting aside of other priorities to be with the people who use. If you're the parent watching your child suffer from couch lock, it's also pretty clear. This kid has a problem with cannabis. But if you're in the other country, worrying about cannabis can seem trivial and off the mark and racist. People of color are certainly arrested and imprisoned proportionally more often for drug-related crimes, and a substantial proportion of those arrests have more to do with what the arrestee looks like and where he or she lives rather than any fair application of the law. The opioid epidemic's lethality makes a joke out of concerns about cannabis. The teenagers who tell me that cannabis never killed anyone are mostly right about that. And Portugal legalized all drugs. Canada legalized cannabis, and 33 U.S. states now allow medical use of cannabis. Vaping has decreased at least the danger to lungs, or so we thought, and has erased the smell of cannabis, so what's the concern? Cannabis is natural, after all, not like those chemicals doctors want you to put into your body. The tax dollars generated from legal cannabis sales, the benefit of retasking police officers from chasing pot-smoking teenagers around, and the rebranding of cannabis use as their personal choice and potential health issue rather than making it a crime, that should be a good thing, right? Except that when I attend AAAP and other addiction meetings, the rooms are filled with researchers and clinicians who deal with young people whose lives are profoundly damaged by cannabis. Not dead by overdose, just slowed down. Cognitively impaired by years of cannabis use, or denied the level of education or work their inherent abilities should grant them. The losers in this particular game of Russian roulette. Cannabis is indeed natural, but so is poison ivy and arsenic. Their naturalness doesn't prove that they are safe. Looking at the befuddled faces of my colleagues at these conferences, I've had the feeling that we are trailing the circus parade into town, dragging the garbage can and the broom to clean up the mess after the last elephant. Everyone else sees the parade, and we just follow along, cleaning up the mess. Citizens of these two countries don't really talk to each other, as they don't share much common vocabulary, to the point that they entirely miss each other when trying to have a discussion. The looks of bafflement on people's faces remind me of what happens at borders and youth hostels and international airports. Folks lean in, talk a little bit louder, slow it down, as if volume or slowing down or easy words will help get the point across. It's not just a language problem, though. The prevailing cultural ethos in these two countries is just so different. In the cannabis is okay country, people's choices shouldn't be constrained more than necessary. And since cannabis is natural and demonstrably safer than cocaine and heroin and even alcohol, it's fundamentally unfair to treat the plant like it's demon weed. And most citizens don't have a lot of experience with people badly harmed by cannabis. Although citizens of these two countries don't communicate particularly well, it's quite easy to cross the border and visit the other country, although you might wish you hadn't. For the families I see who suddenly realize that their 16-year-old has a cannabis problem, the horror on their faces tells me that they really, really don't want to be there. The experience with the cannabis country for the family has always been fine in the past. A short trip, lounging around for a while, and then back home when the vacation is over, ready to get back to real life. Except that now, little Bobby is stuck on his own in cannabis country, and he can't get home, and no one seems to have any good ideas. Members of peer-led support groups like Alcoholics Anonymous often say they have an allergy to drugs and alcohol. And the metaphor works, and explains to the family why mom and dad never had a problem with cannabis when they used it in college, nor did older sister have a problem when she smoked a few joints in high school. But now, Bobby can't seem to stop vaping THC or get himself to school or get out of bed. Unlike everyone else in the family, he is stuck with it. Here's an example of how the two countries see things differently. Early data from the 2014 50-state study about the years 1999 to 2010 showed a correlation between the legalization of cannabis in some states and a subsequent decrease in opioid-related deaths in those very same states. Although the authors cautioned that there was no direct causal link between these two phenomena, headlines claimed that the legalization of cannabis caused pain patients to switch to cannabis from opioids, thereby decreasing the opioid overdose rate. Beautiful. Except that a subsequent reanalysis of the data from 2010 to 2017 showed that the correlation reversed, with more opioid-related deaths occurring in the legal cannabis states and with no correlation at all to be found in either direction for those states with more permissive or stricter cannabis laws. Association is not causation. Cannabis legalization didn't cause the decrease in opioid-related deaths. But look what I just did. I tried to convince you by presenting the cannabis is no good argument last. But maybe I'm wrong. And the next set of papers or cut of the numbers will present a very different conclusion from the data. This is just how medical science usually goes. Point, counterpoint, failed experiment, another try, and eventually, one hopes, a massive evidence which points us towards the best, if not the definitive answer. A few years ago, I heard the drug policy expert Mark Kleiman speak, and he gave his usual nuanced stick-to-the-data talk, talking about the pros and cons of decriminalization of cannabis and drugs in general. At the end, someone stood up in the back and said, fine, Dr. Kleiman, that was great. We enjoyed your talk. But could you just give us your opinion? Is decriminalizing cannabis a good thing, or is decriminalizing cannabis a bad thing? He thought for a second and said, sure, I'll answer you. Yes. I'm afraid we are all citizens of these two countries. As I've been talking to you today, I'm sure that you have noticed the many mentors who have mentored my career, provided an ear, sent me someplace for jobs, etc. If you are not working every day in a hospital or a medical center, or if you live outside of a big city, you know the feeling of being the only addiction person around. Were it not for my colleagues at AAAP, I would be a bit aimless in my professional world. I rely on these meetings for knowledge and on the people I meet here for my collaborators in writing and my resources when I get turned around by a clinical or political or administrative problem. If you get involved in AAAP, as I think you should, you will find an enormous number of doors into this organization. Unlike the Hotel California, you can leave though. But if that door for you is a project that speaks to your passions, mine is law and medicine, you will find yourself in the kind of grown-up play that we call a conference, or a work group, or committee membership. Under the energetic and empowering direction of Executive Director Catherine Cates-Wessel, her staff, and the officers and board of AAAP, it is a true home for the profession and for me personally. For me, being surrounded by my colleagues / mentors / friends like Francis Levin, John Renner, and Shelley Greenfield has made my association with AAAP a delight, and I find myself almost looking forward to going to board meetings. Addiction psychiatry is at a crossroads. Given the profound shift towards a biological understanding and pharmacological treatment of psychiatric illness, including addiction, it's understandable that third-party payers want to compensate psychiatrists for deploying those treatments and letting others do or not do the psychosocial treatment. And in fact, with buprenorphine as an example, there is an argument to make for using life-saving treatment before insisting upon the psychosocial treatment, which might not be absolutely necessary for all. As an important caveat, that psychosocial treatment is going to be necessary for the justice-involved population I often work with, who generally have only paltry social support. But I would argue that fostering a strong therapeutic alliance with the sufferer is really, really important, especially for the addicted person. Of course, even the most effective treatment won't work if the addicted person won't or can't or doesn't use it. It's our job to promote a sense of confidence and hope, which allows the patient to believe, at least for a moment, that his or her life can improve by doing something different. And as I need remind nobody in this room, maintaining sobriety is a long, hard slog. Using the therapeutic alliance to support, understand, and ultimately encourage the addicted person is important for recovery. And my participation in many of my patients' struggles for sobriety over the years has been a source of gratification to me. We cannot allow improving conceptions of addiction's biology to morph into a mechanistic understanding of the disease and its treatment. I'll thank my collaborators at this point. As you can see, although I haven't actually conducted research with most of these people, I have a very long list of people who I'm proud to call mentors and teachers, and to whom I'm grateful for their time, energy, attention, and friendship. Even more than those personal friends, I consider AAAP my professional home, where I've learned my skills and where I hope to pass on at least some of those skills. So practice being clinicians who understand your patients and their struggles, not just prescribers. Mentor your students and colleagues the same way. Don't give in to that simplistic understanding of addiction which minimizes the effect of family and environment and feelings, because ignoring the therapeutic alliance will be a detriment to our patients. As clinicians, we need to stay in this fight. Thanks for your attention this morning.